In this Module 2 video, we'll be talking about various data sources that we use in epidemiology and public health. Our learning objectives are to define surveillance and talk about why it's a vital part of epidemiologic investigation in public health, identify major public sources of surveillance data, and talk about the strengths and weaknesses of different public health data sources, including surveillance systems, vital statistics, registries, and medical records. So to begin, as we said in the last module, ideally we would be able to collect information on everyone in a population, also referred to as a census. This is a good source of denominator data, and it also assures that our data reflect the entire population. But in general, we are stuck with collecting information on only a sample of people. It's often not feasible to collect information on large numbers of people or to contact everyone and get them to participate. So the one exception, or the two exceptions really, that we'll talk about today, when we can get information on essentially the entire population, is the census in the US and also vital statistics. So we'll start with talking about the census. It is, the purpose of the census is not to give us health-related information, although it does a nice job of doing that. It was developed to establish the number of representatives that each state and district has. So this is actually part of the Constitution that we need to do this every 10 years, and the first one was done in 1790. But in addition to collecting just the number of people and basic demographic characteristics, there are a number of other data points collected as part of the census, including health status. And until 2000, this was on what was called the long form, which went to about 1 in 6 households. But now we have moved to the American Community Survey, which is essentially an ongoing survey. It happens every year. And so it collects information about health along with, excuse me, a lot of additional detailed questions that used to be in the long form. There's a link here if you'd like to explore it more. But the ACS now samples about 1 in 38 households every year, and it's possible to do it by paper or now online. So here's an example of a kind of health-related set of questions that is included on the American Community Survey. So these are the 6 disability questions. I won't read them all now, but they essentially cover various aspects of function and sensory disabilities. And this figure is an example of how we could use those data, those 6 disability questions. So this figure shows the number of people in the US living with disability. It's ordered in by decreasing number of people. So you can see that ambulatory disabilities or difficulty walking or climbing stairs is the most common type of disabilities. And the bars show the total number and then the proportion of that occurs among people 65 and older. So for example, for ambulatory disabilities, we can see that about half of those occur among older adults. We can also look at insurance and uninsurance rates for people using census data or American Community Survey data. So this map, or these 2 maps, are showing the change in the uninsurance rate among low-income adults who are working age, so basically those not eligible for Medicare, people aged 18 to 64. So from 2013 to 2014, what was the change in uninsurance rate? And so the more blue color represents a larger change. So that's good. A larger proportion of the population went from being uninsured to insured. And so that's the main map there that you can see. But to the right top of that is another map that shows which states implemented Medicaid expansion during that time. So this was kind of in concert with the Affordable Care Act passage of 2010. Excuse me. And you can see that in general, those states that had Medicaid expansion over the time period also saw larger drops in the uninsured rate. So this is, again, an example of a way that we can look at census data to suggest what's going on in terms of population health. So here are some links if you would like to spend more time looking at census data. The questionnaire itself is linked first. There's a really nice searchable data set for the American Fact through the American Fact Finder, which is linked there. Below that is a link to the narrative profiles. So these are basically already done for you. You can select a county or a state or essentially any geographic subset of the United States, and it will produce a narrative profile of that region for you. So give you some basic census-based data. And if you really want to do your own thing, you could download the public use microdata file, which is linked there. And then if you got really into census data, there are actually sites around the US where you can go to get the identifiable data to do really local level information, GIS sort of activities. So the other data source that's essentially universal, covers basically all of the population, is vital statistics. And so this is really birth and death certificates. So there are standard forms that we use nationally. States could choose to add additional content, but there's a minimum that all states collect. And these forms are actually completed by different people. So it might be healthcare providers, it might be a coroner, it might actually be the person about whom the vital statistic relates to. And here are links to those two files. I won't pull them up now, but they are worth looking at because they probably collect more information than you would think. For example, on the birth certificate, we actually have information about the mother's prenatal care and smoking status, also some information about the father, in addition to all of the details of the child's birth and any conditions that occurred at the time of birth. The death certificate also has circumstances of death and preceding causes of death. So there's a kind of ultimate cause and then underlying causes. So this is very useful in terms of looking at trends in morbidity and mortality, causes of death across the United States. So these certificates typically happen at a local level and then kind of work their way up to the CDC, which aggregates them. And you can get access, I'll come back to that really quickly, to vital statistics data as well. So the Wonder site of CDC is a good place to start. Whiskers also has some vital stats data. And then if you wanted to download the data yourself, those are both searchable online. But if you wanted to download the data yourself, that's also possible through the second link on this page. But going back to thinking about using these data, you want to consider who collects the information. So as we said before, some of it's filled out by healthcare providers, some by coroners, and some might actually be individuals or their family members. And so in thinking about that, you also want to think about what kind of misclassification or bias might be happening. So, you know, if a woman is asked at delivery whether she smoked during pregnancy, you might get a different answer than if you had looked through a medical record to find whether it was ever noted during a prenatal visit. You also would want to be aware of how data are aggregated. As I said, they're collected essentially through local county health departments. So just making sure that you know that the practices are consistent and that there aren't any kind of changes that are being made at a local level that would then show up in the aggregated national data. And ideally, at every stage, there would be quality measures so that there aren't lots of missing data, that people are actually filling out the parts that they're supposed to and not kind of passing it off to someone who doesn't have the training on how to complete them. Okay, so moving on to our more common data sources in public health, those that are about a sample. So the major kind of categories of data on samples that we have are surveillance systems. And so, excuse me, these would include things like surveys, voluntary reporting, sampling. So you could actually take environmental samples like of water, soil, air, and then pharmacy records. We also have registries, medical records, specific studies that are designed to answer an epidemiologic question, and then other data sources that aren't specifically related to health, but that we might be able to leverage for health-related purposes. So we'll talk in more detail about all of these. So first, surveillance system. Surveillance really means it's a systematic and ongoing assessment of population health. So not just a one-off survey, but something that happens consistently over time. There are multiple reasons we might set up a surveillance system. One is to detect epidemics, another is to measure the magnitude of health problems, so essentially collect health statistics for a population. We could also document the distribution and spread of a disease or a health event, which might give us information on how to control it. So there are two types of surveillance, active and passive. So active means that we are going out to find all the cases of disease by periodic contact. So this often happens via healthcare providers. So contacting healthcare providers and asking how many cases of a particular disease like influenza that they've seen. The downsides of active surveillance are that it's costly and takes a lot of time, but it does provide more complete data and better case ascertainment. So you're more likely to have a more representative sample of your population. In passive surveillance, we're just relying on people to report disease that's happening. So this is what we most often end up doing, largely just because of the time and cost limitations of active surveillance. But we ask people to report, so labs or healthcare providers to report particular conditions to a central location, often the local or county health department. So one example of this is the notifiable disease list. And this is a national list. It's periodically revised, but it's a list of diseases that if a healthcare provider or a laboratory sees a positive case of one of these diseases, they are required by law to report it. Although, excuse me, the laws vary somewhat. Every state has some kind of law that governs how this reporting needs to be done. So some conditions are within 24 hours and some could be reported more on like a weekly, monthly kind of basis. So as with the other kinds of data, often this gets reported to a local level, then moves up to the state and finally up to CDC. So all states have to report those conditions that require quarantine that are mandated by the World Health Organization. And currently that's cholera, plague, and yellow fever. But there are actually more than 60 diseases on our list in the US currently. So here's just a sampling of them. You might notice a lot of them are kind of rare diseases that might indicate some kind of biological attack, but others are very common conditions like foodborne outbreaks, which isn't a specific disease, but more of an experience. And so that's really the purpose of that, is so that we can intervene and stop outbreaks. So here's an example of a figure that comes from this reportable disease list data. And this is the number of anthrax cases by year in the US from 1958 to 2013. And you see that actually there was quite a dramatic drop. Anthrax is very rare. And the exception being in 2001 when there were terrorism-related cases of anthrax when it was put in the mail and sent to some newspapers and representatives. Another example here, this is foodborne botulism cases, and essentially all of the spikes here could be linked to a particular food source or outbreak. So again, this is highlighting the reason that we have foodborne outbreaks as one of the things listed on there, so that we can try to track and trace the cause and remove it from the market so that more people don't become sick. So in addition to the notifiable disease list, we have a number of other national surveillance systems that are supported primarily by the CDC. I'll talk about just 3 of them today. These are the National Health and Nutrition Examination Survey, or NHANES, the Youth Risk Behavior Surveillance System, or YRBSS, and then the Behavioral Risk Factor Surveillance System, the BRFSS. So NHANES is a nationally representative sample of people ages 2 and older. There are 5,000 of these done every year, and it oversamples older adults, African Americans, and Hispanics. And the goal of NHANES is to collect both self-reported information and medical and dental exams, so actual in-person evaluations done with medical professionals, which is kind of a unique feature of it. And that's why there are only 5,000 of these done every year, because it's a kind of involved single or multi-day experience to do all of this data collection. And this is an example of some of the data that we can get from NHANES. So this is looking at health insurance status and mortality risks, as comparing people who have no insurance or who are on public insurance to people who have private insurance. And so the darker bars represent unadjusted results and the white bars are adjusted. But either way, we can see that compared to people who have private insurance, those who have no insurance or public insurance have a higher risk of death. The WIRE BSS is focused on youth. So this is a national school-based survey of students in 9th to 12th grade. And it's self-administered, done in the school setting. It's usually about 80 questions. And here's an example of data that we can get from the WIRE BSS. This figure is showing the percentage of high school students who rode in a car or other vehicle driven by someone who had been drinking alcohol. And it's broken down by race and sex. So we can see that overall about 30% of high school students said they had ridden in a car with someone who'd been drinking in the past 30 days. And this was pretty much similar by sex. We see that it was actually slightly more common among Hispanic students. So again, this might inform some of our public health intervention efforts to stop this kind of behavior. The BRFSS is kind of similar to the WIRE BSS, except it focuses on adults. So this is for this is a sample of non-institutionalized adults age 18 and older. It's the world's largest telephone survey, and almost 500,000 surveys are done every year. The CDC supports the BRFSS, and then states kind of manage it on their own. So there's a core set of questions that all states have to ask every year, and then states can choose to add additional questions. And this focuses on chronic conditions, physical and emotional health, demographic and household characteristics, and then also picks up things that might be emerging or of interest each year. Oops. So here's an example of data that come from the BRFSS. So often the statistics that you hear about obesity come from BRFSS data. And these maps just show the change in obesity across time. So in 1990, you can see that the highest category was just 10 to 14% of adults being obese. And then by the time we get to 2010, there are states that have more than 30% of the adults being classified as obese. So it really has been a relatively fast-moving experience in terms of the high proportion of adults in the U.S. who are obese. BRFSS data are downloadable directly. They're free, so anybody can go online and download them. But there's also this web-enabled analysis tool, which is really nice, that allows you to do some basic analysis through the website. And it's, excuse me, the BRFSS data, like many of these national surveys, involve weights to make sure they reflect the underlying population. So they're a little bit trickier to analyze than just standard data, but this web-enabled analysis tool takes that into account, which is nice. So how do we use surveillance data? We monitor changes in infectious agents. We use it to test hypotheses, to look at how our control and preventive measures are working, to detect changes in health practices, and to plan, so using data to drive public health. So surveillance systems are great, but they are expensive to get set up, and since they're ongoing, there's usually also a maintenance cost associated with them. Some of the things that you need to do to set up a surveillance system are to develop the questions, train interviewers, have a data entry process and a quality assurance process, and then also use the data, so have someone available to analyze them and come up with ways to disseminate the data. So usually when we're thinking about whether we should establish a new surveillance system, we think about these factors: frequency, so this is those basic measures of the burden of disease we talked about in Module 1, incidence and prevalence, and also potentially mortality. We think about how severe the disease or condition is, so is it causing people to die? Is it causing hospitalizations or disability? We also consider costs. to both individuals and society, and that might include direct costs or indirect costs. We also think about preventability. So again, if we want to use these data for public health, we want to make sure that there is some way that we could actually use them to inform practice. Communicability is another factor. So if the disease or condition that we're looking at could easily be spread, that might make it more likely that we'd want to do surveillance on it. And then finally, public interest can actually play a large role. So even if something is not particularly severe or costly, or if we don't have a clear prevention strategy, but it's really of interest to the public, and media or other organizations or government officials are involved or interested in it, then it might end up making it to the list of things that we conduct surveillance on. So the strengths of surveillance data are that we typically have broad coverage with it. So as we said before, 500,000 surveys done for the BRFSS every year. So we get lots of people. And again, by definition, it's ongoing and systematic. But the limitations are that the trade-off is typically that with breadth, you lose depth. So a question that you might want an answer to may only have the most basic information on a surveillance system. For example, if someone has diabetes, we might be able to get that and maybe what their last A1C was or how often they check their blood glucose, but we most likely won't have a lot more details about how often they seek care or what they need or what the impacts of their diabetes have been. Also, if we're thinking about passive reporting systems, we can have bias because people may only report the most severe cases or people may not be aware that they're supposed to report, so there can be differences in who reports. And surveys are usually cross-sectional, so that means we only get information at one point in time. We're not able to follow the same people across years, and so that's true with all of these surveys that I mentioned. Each year, it's a new sample for NHANES and BRFSS and YRBSS, so we're not looking at changes in individuals over time, we're just looking at group-level differences across time. So the next type of sample-based data that we'll talk about is registries. And these are when we identify a particular disease or event and we find cases of that disease that are already existing. So this would be prevalent cases. We can do a population-based registry so that those cases represent everyone in the population who has them, but there's still a prevalent-based system, so we wouldn't necessarily be picking up only new cases. We might have a mix of people who have been recently diagnosed and people who have been living with the disease or condition for many years. So we typically do registries for long-lasting conditions, and they're very helpful if the disease is rare. So if there's some form of cancer, for example, or a rare genetic condition that's unlikely to be picked up in a surveillance system. So even if we're contacting 500,000 people, we may only get one or two of a particular disease. Doing a registry would be a better approach because we can instead target those few cases. We can use ICD codes and other approaches to find people who have the disease and enroll them in the registry. So these registries can be useful for understanding the natural history of a disease, in other words, how it unfolds over time, to find risk factors, to look at different treatment approaches and evaluate which ones are most effective, and also to calculate survival probabilities. So perhaps the most well-known registry is the SEER registry, which is Surveillance, Epidemiology, and End Results. It's a cancer registry. It's headed up by the National Cancer Institute, funded by Congress, and it collects data on all cancers in 20 areas within the US. And this one is a population-based registry, so it's designed to be representative of the full US population on some basic demographics, even though not all states are involved. It actually covers more than a quarter of the US population, and it includes information on demographics, tumor site, morphology, stage at diagnosis, people's first treatment course, and then it follows them up for survival. So the benefits of a registry are that you can capture these rare diseases or conditions, you can have a nice clear case definition, and you can make it population-based. But it is potentially time and cost intensive to follow people up over time. You might only be able to collect a limited amount of data on people, potentially only that's included in their medical record. And you might have to have people opt into the registry, which could reduce your size and the representativeness of it. So the next useful source of data on samples is medical or electronic health records. Since the Affordable Care Act required this transition to electronic health records, there is more widespread use, so lots of standalone practices now have them in addition to the larger healthcare organizations like Kaiser or Group Health or the VA, which have had them for years. And Medicare claims are also now electronic. So this might involve chart review, so going through individual notes to find information you're interested in, which is very time consuming and might not be possible if you can't get approval from the organization. The other option is to use administrative data, so that would be things like ICD and CPT codes or medication refill information. But it's important to keep in mind that those data are really designed for reimbursement purposes. So it's not a research wasn't designed to be done to be used for research. So there are limitations to using codes and there may be errors, or there may just be things coded differently than you might think based on what the definition is. So it's important to think about what codes mean in relation to reimbursement and how that might influence how they're used. So the strengths of using electronic health records or medical records is that you have lots of detailed information and they are longitudinal, so we do have data on people over time. But again, the limitations are that we might, chart abstraction is time consuming. It might not be possible to get access because of HIPAA or other confidentiality issues. Also, we would only have information on people who are accessing healthcare services. So if people don't see a healthcare provider, there's no medical record for them, or at least for that condition that they have. And again, using administrative data depends on how accurate the coding is. There can also be a lot of differences across providers just in terms of practices and also in terms of their coding approaches. So another potential source is epidemiologic studies. So a number of large studies have been done over the years and are ongoing now that make their data available to other people. So a few examples are here: the Women's Health Initiative, the Health and Retirement Study, and the National Health and Aging Trend Study. So if you're interested in something that in a population that these studies cover, they would be a good potential data source for you. They typically use validated measures, so that's nice. They also are typically well-designed and longitudinal, have a clear sampling frame, and lots of information to support you in using their data. So things like code books, and they might have already done some data cleaning and calculated variables that you're interested in using. The limitations are that you're basically stuck with whatever the investigators decided to collect information on and whatever sampling frame they decided to use, so it may not perfectly fit your question or your population. There also might be either restrictions on the data use or a delay or even a cost associated with using data. So it depends on the study, but it's worth looking into. And because they are somewhat public, there may be some other group or other people who are using the data for the same thing that you want to look at, which isn't necessarily a problem unless you want to try to get it published first. So other kinds of data that are out there that might be useful for epidemiologic studies or population health assessments are GIS, social media posts, internet search activities, media reports, and then crowdsourced data. So I won't spend too much time on this part, but there's a couple links there that give examples. HealthMap and Flu Near You are both examples of these other kinds of data that can be useful for understanding population trends in health. The strengths of these are that there's a large number of people and it might be easy to get access to aggregate level data. But the limitations are that they're probably won't be individual level data. And again, like some of the other data sources we talked about before, they're not necessarily generated for the purpose that you want to use them for. So it's important to understand how data are collected, what the definitions are. Excuse me. And that large number of people, large number of data points might actually be a limitation. It can be unwieldy to manage or to understand if people show up in the data set multiple times and how to handle that. So that's been an introduction to data sources within public health and epidemiology.